Good afternoon, ma'am.
Good afternoon. We were waiting, so I said, okay, let them start doing the pre-test. Today, this pre-test will take little time because Dr. Narendra Chaudhary has taken a particular, uh, you know, effort to include the imaging also in the questionnaire, so that it is very explanatory. People can recognize visible effect would be there. So maybe they will take today a little more time to do the pre-test, but this will be worth doing it. And I thank Dr. Narendra Chaudhary for doing such a wonderful exercise for this pre and post test.
Thank you, ma'am. Let's let them do the test. Then it will be evident how much.
We will know how performance will tell us, how was our performance. I take it this pre and post test also a way of gauging, how was our session? Was it good, bad, addressed all the area of concerns raised in the pre or post test. So it is in fact a test for ourselves also.
Sure.
Thank you, ma'am. Thank you, sir. So welcome all for the 9th session on the early recognition of chest injuries. Now I request Dr. Deepika Sharma, ma'am, to welcome and address the participants on the today's topic. Over to you, ma'am.
Thank you, Sifri, and a very warm welcome to all of you in Standard Treatment Guideline series. And first of all, apologies, like Dr. Srivastav and Dr. Atul Kotwal, they have just traveled back from the Srinagar yesterday night only, and today they both are stuck somewhere, so they will not be able to join for this particular thing. But I think they will be joining online whenever the time will permit. So as Siddhi and Dr. Sangeeta Ram has already informed that our today's topic is early recognition of the chest injuries. And we know that chest injuries are usually caused due to road traffic accidents, falls, stabbing, gunshot, industrial accident, and contact supports, etc. And typically injuries are caused by blunt mechanism. It may be direct or it may be indirect, compression, contusions, etc. And there are number of evidences and studies which say that chest injuries account 25% of all deaths from the traumatic injuries. And there are few evidences which also says that 1 out of 4 trauma deaths are due to the chest injuries or its complications. Focusing on this important health problem and its diagnosis and management, today's session is identified. And with us, we have Dr. Narendra Chaudhary. Sir is additional professor, Department of Surgery and Critical Care Unit from JP Trauma Center, AIIMS, New Delhi. Apart from this, we have to talk about the complexity, challenges, and solutions of the chest injuries. We have Dr. Sangeeta Sharma, ma'am, and I think ma'am is known to all of you, and ma'am is a professor in IBHAS. And I hope this session will bring new knowledge and elegance in your practices, and all the specialists, doctors, CHO, staff nurses, and professionals who from the different discipline who has joined us from far-flung areas get benefited from this endeavor. And a very warm welcome to all of you once again, and over to you, ma'am. Thank you.
Thank you, Deepika, for setting the scene and selecting this topic. This is a very, very pertinent topic, keeping in mind the number of trauma cases that we have. This has become a third burden of the disease in today's world, especially in the metro cities. Besides infectious diseases, non-communicable diseases, roadside traffic injuries have become the third burden of which is causing a lot of lives and needs immediate care, pre-hospital care, primary care at the emergency center, and of course the specific management of the trauma that has been caused. I was looking at the attendance of the last series, and we had one session on trauma. Dr. Amit Gupta, also from the AIIMS Trauma Center, he took this session, and I was just looking at the number of people who attended, it was in thousands. I was really, questioning, Siddhi, is this the correct number in the
Yeah.
snake bite? I couldn't believe it. Snake bite session, more than 3,000 people were there. Hypertension people, more than 2,000 people were there. So I was a little, is something wrong with the number, or it was the actual number? This is for Dr. Narendra Chaudhary. This is the kind of participation that we have, and we have people joining from all corners of the country. Right from the tertiary care, district care level, and then we have people from CSC, PSC. Some of the nurses also are very keen to learn about it, because some of the centers have only these people, nurses, besides the doctors, are providing the major care. So that's the kind of the demographics of the participants that we have. I think people, we have, this pre-test been posted there. We've got responses from 60 people right now. I think the others are in the process of attempting it. We'll wait for five more minutes. Let them complete, because today's pre-test has a lot of imagings also. And I think those will be educative, will be helping you, because you will be able to associate these conditions or these type of X-ray pictures, to what you see in your emergency department in the hospitals. I think you are able to open the link. There is no problem with it. Many have already actually submitted it also. In the previous sessions that we have, responses from 65 people so far. Kindly do it. One of you got all 20 right. Oh, that's great. Dr. Narendra Chaudhary, आपने तो नहीं किया वो वाला टेस्ट?
Nice, ma'am. Yeah.
But it is very, encouraging to see that one person has got full 20 marks.
Oh, that's
I think we haven't got credit hours for this program. Maybe next series we will get the credit hours. Right now you get the certificate only from the NHSRC. Siddhi, I don't know, one of them is writing that cannot open the link.
Ma'am, maybe internet issue, because I have opened here also, it's working fine.
Okay.
I have again posting the link so that they can try from the different server.
Ma'am, shall we keep last 30 minutes for discussion?
Yes, definitely. That's the most important part.
Right.
1 hour is with you, maybe more. I'll be just summarizing it today. I don't think so. I have much to add, but to summarize what you'll be saying.
Yes, ma'am.
I think, shall we start, Deepika? It's already 15 now. People can continue
Yes.
attempting. I think, Siddhi, you can introduce Dr. Narendra Chaudhary.
Yes. Good afternoon. So today we have Dr. Narendra Chaudhary with us. Sir is MS FACS, additional professor trauma surgery and critical care at AIMS New Delhi. Sir is fellow of American College of Surgeons, also Asian Collaboration of Trauma. Sir is also fellow of Indian Association for Gastrointestinal Surgeon. Sir is also an instructor for advanced trauma life support and advanced cardiac life support. Thank you, sir, and over to you, sir.
Thank you for the kind introduction. And today, good afternoon, all the attendees and respected panel members. So today, I will take you through the chest trauma management, how to recognize them and how to manage them. So chest trauma is always poses an enigma to the surgeons, and mostly the general surgeons treat them. Many of the times when the chest trauma happens, they happens in a far-flung area, and usually the specialized care is not there. But diagnosing them and managing them should be required at that moment. Otherwise, these traumatic conditions can be catastrophic. So today's lecture will all about how to recognize them with the minimal available resources. So when you are attempting the pre-test, you have seen that most of the pre-test is either the problem based or on the X-ray based. Only one or two pre-test questions are based on CT scan. So we can just expect that management of chest trauma doesn't require many of the sophisticated investigations or a very well-trained person. Yes, few of these trauma requires, but majority of the traumas can be treated at the site where it was inflicted and with the minimal resources. So with these starting lines, I will start today's lecture. So greetings from All India Institute of Medical Sciences and JPN Apex Trauma Center. So JPN Apex Trauma Center is a part of AIMS New Delhi, and it's a level 1 trauma center. Level 1 is the level that the highest level that we designate to a particular trauma center. We can designate into 4 parts, level 1, 2, 3, 4, depending on the conditions, the facilities available, the resources, manpower and infrastructure, as well as the academic course they are running. So all these combinedly gathered together and evaluated, and then we list them as a 1, 2, 3, 4 trauma centers. So level 1 is the highest level, level 4 is the lowest level, and usually the district hospitals or the primary health centers are usually designated as level 1 trauma, level 4 trauma center. We as a Apex Trauma Center encounter almost 70,000 footfall in our emergency room in a year. So uh, uh, it it roughly calculates into 200 to 250 patients in a day. Out of them, almost 20-30 patients are seriously injured patients, and usually they get admitted, and rest of the patients are usually managed in the emergency or transferred out somewhere else in the wake of availability of the bed. So if I say about the thoracic trauma, to summarize in the 2 lines, the first line is a major cause of preventable deaths in trauma patient. So thoracic trauma per se, if recognized in a timely manner and the management can happen in a timely manner, usually we can prevent the deaths. This is one of the major cause of preventable death. But at the same time, if it is not recognized or the subtle findings has been overlooked, then it may be a catastrophic condition and patient can die. Another peculiar thing about thoracic trauma is majority of the thoracic injuries don't need a surgeon. So here as a surgeon, I'm saying you that even if you are a plain doctor or MBBS, or maybe you are of some other specialty, the initial management, the majority of the thoracic trauma patients can be managed at your level with whatever resources you have at your working place. That doesn't require very highly skilled surgeons or any specialist. At the same time, they also doesn't require very sophisticated investigations to diagnose them. In majority of the times, the thoracic trauma usually diagnosed on clinical examination and with the minimal resources like ultrasound and X-ray. They are the things that you can actually diagnose almost 90 to 95% of the thoracic trauma patients. And once the timely diagnosis has been made, you can actually treat them and manage them. For the management, there is a dictum that in blunt thoracic trauma patient, almost 90% of the patients usually managed non-operatively, or you say conservatively without any operative intervention, or sometimes they requires an intercostal tube drainage or tube thoracostomy that can be placed even by a plain MBBS or any of the treating physician or anyone who has completed the graduation. At the same time, if we say about the penetrating trauma, almost 20 to 30 patients only requires some operative intervention. Rest of the 70% of the patients can be managed expectantly with a conservative intent, non-operative management. So in trauma, whenever we say conservative, our intent is for non-operative management. NOM is a standard term in in a trauma literature, where our intention is to treat them without any operations in an expected conservative way till either the patient is discharged or sometimes when patient dips, he ultimately requires operation. But as I told you, only very few fraction of the patients actually requires operative intervention. Majority of the patients will be treated without any operations with expected management. Most of the time, even without an ICD, in some cases, an ICD is required. That's all. So it's a dictum that an ICD at a time saves multiple of the patients. So to highlight whatever I told you, I am just giving you a case scenario. This is a real case scenario that we came across about 2-3 years back, where a 16-year-old male with mechanism of injury is road traffic injury. So he arrived at our trauma center, not the primarily one, but initially treated somewhere else, and then arrived in our center with the referred case with the mechanism of injury is road traffic injury. So mechanism of injury in any of the trauma patients, whenever we shift the patient from one place to another or from accident site to the treating hospital or the receiving hospital, we always send the information in the form of mechanism of injury. What was the mechanism? It's very important because it will give us a clue that which organs get damaged or what are the effects that that particular injury, that particular collision will have on the patient. So if the motor vehicle collision is there, head-on collision is there, maximum energy transfer is there, and we can expect in the patients like head injuries or the spinal injury if they are not restrained with the seat belt. So mechanism of injury will tell you many of the findings that you can expect to be there in the patients who will be coming to you in a moment of time so that you can prepare your ER, your hospital according to the need of the patient. Whenever a patient arrives in a treating hospital, we always follow the primary survey. Primary survey is nothing but primary survey is just uh, structured evaluation program where we always find out the life-threatening injuries first and treat them initially rather than going towards the anatomical details or a detailed survey. So primary survey, just look for the life-threatening injuries, treat them, restore the physiology, and then go for a secondary survey, which is about a detailed evaluation or structure. So during the primary survey, he has a problem in B and C part. So A stands for airway. I think everyone knows that. B for breathing and ventilation. Breathing as well as ventilation both are important. C is for circulation. All the hemorrhages usually we look in the C part. D is for disability, the head injuries, the GCS, the localized lateralizing signs, pupillary reactions, all these things we will see in D. And E is for exposure and environmental control and preventing hypothermia. So during the primary survey, he has the right ICD placed with persistent air leak. So persistent air leak from one of the hemithorax is usually a sign of either the lung parenchymal injury or an airway injury. It will depends on the grade of the air leak. I will take you in the coming slide. So at the moment in the emergency room during primary survey, his B was abnormal. He had an ICD on the right side and persistent air leak was there. And he was referred to us after 18 days of injury. He was managed somewhere else, and then ultimately, in view of the persistent air leak, he was referred to us. So you can just look at the air leak. So these two are the ICD bottles, or you can say chest drain kits. We always prefer a plastic chest drain kit in the form of bottle rather than a polythene bag. I will let you know in the coming slides that why this particular bag is important. At the same time, you see the magnitude, the quantum of air leak. Air leak is continuous. Just I'm repeating the video. You see the air leak is continuous. It doesn't have any relation with the inspiration, expiration, coughing. It's continuously leaking out, whatever phase of the patient is having. So which grade it is? It's a totally a clinical picture. Or I think placement of ICD and looking of these ICDs can be done even in the primary health center. So it's a grade 4 air leak. So I will take you in the coming slides. The air leak can be divided into grade 1 to grade 4. Grade 4 is the most severe one, and it shows that some major airway injury is there. That's why there is no relation with the inspiration or expiration. Whatever phase it is there, the air is continuously leaking. Again, during the primary survey, we need the very simple investigations in the form of ultrasound or in the form of X-ray. So here you can see the chest X-ray. So again, the reading of chest X-ray has a particular uh, structured way in the trauma so that we should not miss any of the findings. So like ABCDE, we always read the X-ray in the same form. A stands for airway, where we can see whether the airway is within the midline or it is opacified or not. B is for the breathing apparatus, the bilateral lung. Here you can see in the B part, there is a homogeneous opacity despite of one ICD that is placed on the right side. So ICD is already placed on the right side of the thorax, but still residual air is there and continuous air leak is there. It shows that the magnitude of air is so much high that the ICD is not sufficient enough to drain it out. That's why we place the second ICD. Even after placement of the second ICD, if the persistent air is there, it shows that some major air leak is there that is continuously built up inside the chest cavity. The same patients again went for the CT scan, but trust me, the CT scan is only done once the patient is referred to us. During the primary treating facility, this patient was not underwent CCT and it was not required also. Majority of the air leaks will get sealed within 5 to 7 days of placing the ICD by themselves and doesn't require any operative intervention. This is the air leak that is very high in the magnitude. Grade 4 air leak is there. That's why the further investigations are required. And such patients constitute only 1 or 2% of all total chest injuries. So here you can see on the CCT chest also, the contrast enhanced CT of chest, that right-sided complete homogeneous opacity is there. And it shows the air is there. There is no lung parenchyma seen. And you can see the ICD that is placed inside. So a plan of right posterolateral thoracotomy was done in view of major airway injury, and right-sided pneumonectomy was done in view of the right main bronchus transection. So patient had the motor vehicular collision. He had the right-sided main bronchus injury, and over the time that injury is converted into a complete disconnection between the right main bronchus and the main stem bronchus, and ultimately converted into a grade 4 air leak, and it was operated. So my question is that who saves this patient? You can put in the chat also. Who saves this patient? Either we saves here at the level 1 trauma center, or the first physician who attended him, who diagnosed him, who placed the ICD and then referred to us? So my answer is simple. The first one who diagnosed him as a chest injury and who placed the ICD in a timely way is actually the savior of this patient. If this injury has been not diagnosed in the initial time, this patient will die at the spot or during the hospital. So that's why this is the critical point in the chest injuries, that once, if you are the first center that is receiving the patient, then you must be very vigilant for the chest injuries. You should diagnose them timely and you should manage them timely. Most of the injuries can be managed with ICD. Few of them requires operative, but once you place the ICD, patient has that time to be shifted to some specialized center and ultimately the patient's life can be saved. So here the person is saved because of the vigilance of the first doctor who has seen him, diagnosed him, and placed ICD and then referred to us. We are not the person who saved this patient. Okay, let's have the case 2. The second case, again, a 25-year-old female. Mechanism of injuries, road traffic injuries. Primary survey, now you are clear. Primary survey is ABCDE and he or she is a responder. Responder means once the patient arrives to you, you give him the challenge of 1 liter crystalloid, maybe the RL or NS, whatever is available. And if patient BP become normal or patient's vital become normal or they are remain within the normal limit, it means the patient is responder and you can further go ahead for a detailed survey. If the patient's blood pressure is not shoot up within the normal limits after giving 1 liter of the crystalloid, it means patient has lost much more blood than the 1 liter which we gave him right now, and the patient is labeled as non-responder. But in this particular case, this 25-year-old female responded to 1 liter of the crystalloid and ultimately labeled as responder. Her BP and pulse rate are within normal limit. She has the left femur shaft fracture and she was admitted under orthopedics in trauma center. It was very clear the isolated fracture femur shaft and patients admitted in orthopedics. Stage 0 X-ray. At the arrival, X-ray was all right. You can see the A, airway, the breathing apparatus. C is the cardiac shadow. D is both the diaphragms, where you have to trace the diaphragms in their entireties, and it can be, you will be able to trace. And usually the right sided diaphragm is slightly higher up in the level as compared to the left sided diaphragm. So all these findings are suggestive of the normal chest x-ray, and ultimately the E is the extras. Like in the previous x-ray, we have seen one ICD was there. So ICD is there. Sometimes you can see the central line. All these things are the extra line. Sometimes you can see the endotracheal tube also. So these all are to be taken care in the E part. So ABCD is E is a way to read the chest x-ray also. Okay, you have a lot of x-rays in your pre-test, so you can correlate now. Day 1, what is the spot diagnosis? Patient femur fracture, young female, shaft femur fracture, all of the left-sided lung is white out. What are the differential diagnoses you can have with this X-ray on day 1? And patient is not ventilated. She was in the ward, and on the day 1, she had all white out lung. Patient GCS is full, so she can clear her throat. She has the intact cough reflex. So mucus plug is an unlikely diagnosis in this particular case. Can anyone type in what is the differential diagnosis? Day 1 chest X-ray. Even the cardiac shadow is shifted slightly towards the right side. All of the left. Embolism, again, embolism is not a differential diagnosis here. Fat embolism definitely is a risk for the shaft femur fracture, but usually they will appear as a mnemonic patches or some dot white patches. They are not like homogeneous one-sided opacity. They can have the bilateral opacities because it is a blood-borne embolism, and homogeneous unilateral opacity is not because of pneumothorax. which sided? Do you think pneumothorax on the left side? Air is always black, homogeneous black, but here we see the abnormality in the form of white shadow on the left side. So it's not an air. Left-sided is white, air is black. So left-sided pneumothorax is not a diagnosis here. It's a diagnosis of left-sided hemothorax. Always mind that these patients, trauma patients, X-ray are always done in the supine position, and the whatever the liquid is there inside the chest cavity in trauma, we say it's blood. In a respiratory medicine OPD or in a normal physician's OPD, these type of pictures can say massive pleural effusion. But here we have usually the young patients without any tubercular infection over the lungs and after a history of trauma. So we always consider them as a blood in the pleural cavity rather than the effusion. So it's a diagnosis of left-sided hemothorax. One of the reply is in the form of massive hemothorax. It may be, but we can only label it once we place the ICD. So now what you want to do in this particular case? Patient is maintaining her vitals. Day one X-ray is like this. What will we do? As I told you, majority of the cases can be managed non-operatively with expectant management or in the form of ICD. So we place one ICD. Can you see the ICD in extras, the left-sided ICD? And it was like 1 liter of the blood has been drained out and the lung shadow again appears and the this cardiac shadow is also shifted to normal position. So after getting 1 liter of the blood in the left-sided chest, no more blood came out. So it was not labeled as a massive hemothorax. But if it was more than 1500 cc, then we can label them as a massive hemothorax. I will take you through the massive hemothorax also. But it was a left-sided hemothorax and very well managed with the placement of the ICD. This is the day 5 X-ray. You can see the chest is improved drastically. So this is something. So with last two injuries, we came to a conclusion that diagnosing them timely and putting the ICD is usually a life savior in these patients. The previous patient, the young female, didn't require any of the operative intervention. She only requires an X-ray to be diagnosed and an ICD to be treated. That's all, nothing else. So this is the peculiarity of these thoracic injuries. So we should be able to diagnose them timely with the available minimal resources. Both the patients were diagnosed on the chest X-ray, no more sophisticated investigations required, and both of them treated with ICD in initial time. Of course, if that ICD is insufficient to treat them, then they can be referred to higher center, but that fraction is very small. Majority of the patients get responded after placing the ICD, and you will be able to discharge them in the time of 5 to 7 days. So now I will be coming for the outline of the thoracic trauma. So I will give you an overview of the thoracic trauma in the coming slides. ED management, the emergency room management or emergency department management, very important because few of these injuries are immediately life-threatening injuries, and we should be very vigilant when we are attending these patients and managing these patients. So they should be managed in a holistic way. And third that I will going to discuss is intercostal tube drainage. Although it looks like very simple, putting a tube inside the chest and connecting it to an underwater seal and the job has been done. Yes, the job has been done, but you should have that skill and you should have in your mind that what should I do, what should I don't do, and how to manage these ICD patients, as well as how to take care of those ICDs, when to remove the ICDs, what size of the ICD should I place, in which position I place, at what site should I place. All these things I will take in the detail in the coming slides. And ultimately the definitive management here, because 90% of the blunt chest trauma is managed non-operatively, 70 to 80% of the penetrating chest trauma has been managed non-operatively. So this is the major area where I will put the stress. Of course, few of these patients requires operative management, less than 10% in blunt trauma, and around 20% in penetrating trauma, that in the form of either thoracotomy or video-assisted thoracoscopic surgeries. I will touch upon briefly on those parts, but my main thrust will be on the non-operative management, because with the non-operative management, you can manage majority of the cases, and whatever place you are posted, wherever you are working, yes, you can manage. The operative management is important for those patients, those doctors or the physicians who are actually posted at a higher level where resources are there, and they will get the selected referred patients. So I will touch that also for those specific doctors population also, but main thrust will be on the non-operative management. So thoracic trauma. Thoracic injuries are sudden and dramatic. So many of these injuries are eye-catching. They will attract the physician's attention immediately, and sometimes these thoracic injuries uh, can actually overshadow more life-threatening injuries in the form of airway obstruction. So whenever we are treating these patients, we should always follow the ABCD principles, because the highest threat to the life should be treated first, and the highest threat to the life is airway obstruction. Then comes the chest. Another thing is that they are almost responsible for 20 to 25% of trauma related deaths. So if we calculate the 100 deaths, almost 25 of deaths are because of these thoracic injuries, maybe some life-threatening, immediately life-threatening injuries that were not diagnosed immediately, or they were so serious that the patients was not able to make it to the ER of the hospital, and they die either in the pre-hospital care or at the spot of the accident. Another thing is, in these trauma related injuries are there, those injuries which are potentially life threatening. They are not immediately life threatening, but they are potentially life threatening if overlooked. So it's very high chances that an unskilled or a novice physician can overlook them in the primary survey in their ER. And once they get overlooked, they have that potential that the patient can end up in the problems, or they can sometimes be catastrophic. So I will take you in the coming slides that what are the potentially life-threatening injuries and what are the immediately life-threatening injuries. Then the treating physician should have a very high index of clinical suspicion. He should be thorough in the clinical examination, right from the list, the inspection, palpation, percussion, as well as the auscultation. So auscultation is very important in these patients, and the physician should always rely on their clinical examination. Clinical examination is one of the important aspect that will give you the clue. So you should always have a high index of suspicion. Even the patients who are hemodynamically stable and who are apparently looks like there is no injury, but still he can have lung contusion, he can have rib fractures that may not be evident enough during the primary survey immediately after the accident, but they will reveal themselves in the coming 72 to 98 hours. So, but you have to be very suspicious. Then mechanism of injury. Usually in Indian scenario, we come across the blunt trauma majority of the cases. Penetrating trauma is relatively lesser as compared to the blunt trauma. It's almost opposite to the Western literature, where majority of the chest injuries are after the penetrating injury in the form of the high velocity gunshot injuries. Here in India, majority of the chest injuries are because of the road traffic injuries, and they usually categorized into the blunt trauma. So in Indian context, it is even more important, because less than 10% of the blunt traumatic chest injuries actually requires operative intervention. So as I was discussing, there is known as deadly dozens. So there are total 12 conditions in the chest that can either the immediate life-threatening or the potentially life-threatening. Immediately life-threatening means they are immediate danger to the life, and if they are not diagnosed immediately, then they will be almost invariably lethal to the patient. Whereas the potentially life-threatening injuries are the injuries which are usually settled at the presentation, where high chances that the examining physician can overlook them. And once they get overlooked, they will be problematic for the patients. They will get developed further, and ultimately the patients can have life-threatening injuries. So if we say immediate life-threatening, they are the tension pneumothorax, open pneumothorax, massive hemothorax, cardiac tamponade, tracheobronchial injuries, and traumatic cardiac arrest. So one thing is common in these findings. These conditions will not require any of the sophisticated investigation to find them. These injuries are usually diagnosed on the clinical examination, and only clinical examination is enough good to diagnose them and to treat them. We should not wait for any of the investigations in the form of even the x-ray or the ultrasound, or forget about the CT scan, but even the x-ray is not mandatory to find out the tension pneumothorax or the open pneumothorax, because they are very serious injuries and they need immediate attention of the treating physicians. And how to manage them, I will take one by one in the coming slides. Then the potential life-threatening injuries in the form of simple pneumothorax. Usually, it's simple pneumothorax is very simple, it's not life-threatening, but sometimes it poses a challenge of converting into a tension pneumothorax. So if the simple pneumothorax overlooked, then there may be chances that ultimately usually in majority of the patients, simple pneumothorax will resolve by itself, but in few of the patients, it can convert into a tension pneumothorax. If one-way valve mechanism is formed, then it becomes a life-threatening conditions. The same happens with the simple hemothorax or normal hemothorax. If hemothorax, usually these patients are hemodynamically stable, and usually this finding is usually evident on the x-ray or when a vigilant clinical examination has been done, then it can be found out. But if it is overlooked, it will be converted into a retained hemothorax, pyothorax, sepsis, and ultimately maybe the life-threatening. Pulmonary contusion, again, one of the potentially life-threatening injuries. Initially, it doesn't have any problem, but once they get evolved over next 3 to 4 days, then there will be the lung edema, and ultimately the gas exchange will hamper, and the patient can go in the respiratory arrest or the respiratory failure. So pulmonary contusion is also one of the lethal condition that is not immediately evident, and if it is overlooked, they can be potentially life-threatening. Same is applicable for the flail chest, where 2 or more ribs get fractured at 2 or more points, and there will be a detached part of the chest wall from rest of the chest, and it will have a paradoxical movement with the breathing, and it will hamper the ventilatory efforts of the patient, and ultimately the gas exchange will not happen, and the patient went into the respiratory failure. The diaphragmatic injury, they may not be lethal immediately, but if it's overlooked, ultimately the abdominal viscera herniates into the diaphragm wherever the diaphragmatic injury is there, and ultimately that sided lung get collapsed, and patients can have empyema, pneumonia, and respiratory compromise. Esophageal injury, again, same thing. They are not immediately life-threatening, but if overlooked and if esophageal injury is there, then ultimately the mediastinitis will be there and the patient will have a life-threatening event. So these 6 injuries are not immediately life-threatening injuries. There are higher chances that we may not diagnose them during the primary survey, specifically the diaphragmatic injury and esophageal injury. But primary survey give us the clinical examination as well as the x-rays and ultrasound, and majority of these injuries can be delineated with the help of adjuncts to the primary survey in the form of X-ray and ultrasound as well as the clinical examination. At the same time, it is also true that the patient who sustained potentially life-threatening injuries are usually the hemodynamically stable patients, and there is a time to evaluate them further with the help of the CT scan, and CT scan is very sensitive to rule out all these injuries. But this is not true for the immediately life-threatening injuries. These patients are hemodynamically not stable. They are not fit to be shifted to the CT scan, even not fit to wait for the X-ray to be done. So these injuries usually diagnosed on clinical examination, and we have to do the management also during the same time. What type of management we should do? I will take you in the next slide. Then our experience in thoracic trauma. So the yearly admission, the last year we admitted almost 2,000 patients, near to the 2,000 patients, and out of them, almost 38% of the patients are of the chest trauma, and majority of these chest trauma patients are following the blunt trauma in the form of road traffic injury, fall from heights, or interpersonal violence. Out of these 672 chest trauma patients, almost 90% of the patients, to the tune of 600, has been managed with non-operative intent and with the expectant management. And among those 600 patients, almost 424 patients required an ICD as a part of non-operative management, and 171 patients managed even without ICD, with totally non-operative management. So now you can see that even at the level 1 trauma center, almost 90% of these chest trauma patients are managed with simple form of non-operative management or sometimes with the ICD. So the same population you will also receive at your center, uh, uh, even the number of non-operative management patients may be more in your center, because we as a specialized center also get the referred patients. So we have very specialized population group. Still, among those specialized population group, we are able to manage them 90% of these patients with a non-operative interventions. Operative management, only 77 patients required, that constitute about 11% of all chest trauma admissions that happened in our center. And majority of them has been operated for retained hemothorax. One of the complications that is followed after a hemothorax, which is considered a potentially life-threatening injury, not an immediately life-threatening injury. And once that hemothorax is incompletely drained with the ICD and it is remain there, we call it as a retained hemothorax. It has the capability of converting into an empyema or fibrothorax or sepsis. So it is mandatory to evacuate those retained hemothorax. So something about blunt trauma. Since in Indian scenario, majority of the patients are following the blunt trauma, and these blunt chest trauma can present in a varied way. Here in the first picture, you can see a seat belt restrained patient who had a head-on collision, and that seat belt mark you can see over the chest. So here, if you find such type of findings in a patient whom you are going to attend in your ER, you must be very suspicious about the underlying chest injury. So always vigilant for these type of the clues. It's one of the clue that shows that this particular patients may have internal chest injuries uh, correlated with the transfer of energy that has been seen over as a seat belt mark. Another point you can see here, a blunt thrust over the chest where multiple rib get fractured and a part of the chest goes inside, a type of the flail chest. So again, if such type of findings are there in the adults where usually the flail chests are associated with the lung contusion, you should be very vigilant. If patient is hemodynamically stable, you should at least place a chest tube and send the patient for the CT scan so that further evaluation can be done. Then in the form of penetrating injury, you can see the impelled injury. So here, if the penetrating object remains inside the body, then we call it as an impalement injury. If it has been removed at the site of the scene, then we say it a penetrating injury. So both the things are the impalement injuries. You can see one of the iron rod that is crossing the chest and the abdomen through and through, and he was referred to us for the management. And another, you can see a screwdriver that is placed inside the chest over the cardiac box, you can see. So these are two of the findings that are also gives you a clue that the underlying organ get damaged and you should be very vigilant. So penetrating trauma, these type of injuries, they definitely requires operative interventions in the form of thoracotomy, but at the same time they are not so common injuries. I can say that even among the majority of the attendees, they have not seen such type of the injuries. So they are very rare, but yes, if such type of injuries are there, then they need the operative interventions. That's why I was telling even in the beginning that penetrating injuries, yes, almost 30 to 20 to 30% patients requires operative intervention. Now something about the extent of injury. So by the virtue of the chest, that includes all the vital organs in the form of both the lungs, the heart, great vessels, esophagus, the airway, the trachea, and the bronchi. So chest injuries virtually can impair uh, uh, any of the component of the primary survey. It can affect the A part, the airway part, because majority of the airway is within the chest, including the lower part of the trachea and both the bronchi. Then it can affect the B part also because both the lungs are situated in the chest. Then it can also affect the C part because the heart is there, the major vessels are there. So sometimes the blunt trauma or the penetrating trauma to the chest can injure the heart, can rupture the heart, and it will be presented as a problem in the C part. They can injure the great vessels, major bleeding can happen, patient go in the hypotension, and they will affect the C part. So chest trauma has a peculiarity that it can affect the A, B, and C component of the primary survey. So you should be very vigilant for these injuries. At the same time, the chest wall injuries are also one of the clues for the patients. If you find the chest wall injuries in the form of flail chest or rib fracture in an adult, you should always suspect the underlying lung contusions or the pulmonary contusions because usually in the adults, the ribs are rigid one and they transfer the energy towards the lungs. But this is not true in the pediatric patients where the ribs are flexible and they will absorb all of the force of the impact on by themselves and the underlying lungs can still be saved. So whenever you find such type of the chest injuries, you should always look for all these organs at together and even not to forget the diaphragm because the diaphragmatic injury can also be not the immediately life-threatening, but it can be a potentially life-threatening injuries. Then what actually happens in the chest trauma? Why it is so important? So what happens in the chest, in the lungs, the alveoli is the unit of the lungs where the gas exchange actually happens. So from the environmental air that we breathe in, the O2 get absorbed through the pleural membrane and the CO2 is exhaled out through the capillaries of the pulmonary capillaries. So whenever there is any problem in the lungs, the lung injury is there in the form of lung contusion, or when there is a chest wall injury that hampers the breathing mechanism, then ultimately this gas exchange will get hampered and it will be revealed in the form of hypoxia or hypercarbia, or ultimately the hypoventilation in the when the chest wall injuries are there, and it will leads to ventilation perfusion mismatch and metabolic acidosis. So being a vital organ, the lungs being a vital organ for the gas exchange, this gas exchange can get hampered because of these clinical conditions of the chest trauma, and this will ultimately leads to the ventilatory failure, the VQ mismatch, and ultimately the hypoxia and metabolic acidosis. So our purpose is to restore this physiology again, and this restoration of physiology should be immediately because once this restoration of physiology takes time and the physiology has been deranged in a way that it becomes irreversible, then it's very difficult to revive the patient. So we have to recognize them in a timely way before the physiology deranged to a point where it becomes irreversible. So we have to act swiftly and we have to again establish this O2 CO2 exchange at the alveolar level so that the injuries will not become ultimately the lethal one. And we have to act when they are within the reversible phases. And the good thing is that in the initial phase, they are reversible, but once the injury got overlooked and the patient is shifted to the ward or patient is discharged in wake of no abnormality during the primary survey, then actually these injuries get developed over the time and ultimately they become catastrophic. Now something about the emergency management of the thoracic injuries, as I discussed initial also. So priorities do not change, whether it's a chest injury or the airway injury or the abdominal injury or head injury. Our priority remains the same, A, B, C, D, E, airway, breathing, circulation, and then disability. Because our primary aim is to manage the greatest threat to the life first. The injury that has the highest potential to derange the physiology has to be treated first. And here the highest potential to rearrange the physiology is the airway, because the complete gas exchange will hamper once the airway obstruction is there, and the patient will die in minutes. So that's why primary aim is to rule out any airway injury. Then comes the lungs, because the gas exchange will not happen even in the lung injuries. So then we have to see for B, C, D, and E. Then there are few adjuncts in the primary survey that will help the examining clinicians to reach a workable diagnosis and to find out these physiologically deranging injuries in a timely way. They are like vital monitoring, saturation of the oxygen, arterial blood gas analysis, hemoglobin, NG tube placement, nasogastric tube, urinary catheters, because we can find out the urine output as well as whether the blood is there or not, chest X-ray, X-ray pelvis, fast and diagnostic peritoneal lavage. Of course, DPL is now out of the favor and now it's not considered, but till fast, these adjuncts are really very helpful for you. These all injuries, as I told you, are the immediately life-threatening injuries. They will be managed primarily during the primary survey. Resuscitation is also goes on. And ultimately, once we treat all these immediately life-threatening injuries with the help of clinical examination as well as the help of adjuncts, and the patient is hemodynamically stable, then we will reevaluate and ultimately we reach to the secondary survey. In the secondary survey, we can take help of the CT scans, MRI, or some special studies, which are not the part of the primary survey. So you will be surprised that all these sophisticated investigations are not required for the initial management of even the seriously injured trauma patient. The seriously injured trauma patient requires a clinical examination and a few simple investigations in the form of saturation monitoring, ABG, nasogastric tube placement, and monitoring the vitals. Those patients whose primary survey has been completed, hemodynamically stable, should be subjected for CT scan, because radio suits are usually considered the graveyard for hemodynamically unstable trauma patients, and we should refrain ourselves for shifting the hemodynamically unstable patients for evaluation, detailed evaluation in the CT scans. Only and only the patients who are hemodynamically stable are the patients that are should be subjected for detailed investigations and where actually the potentially life-threatening injuries can be ruled out. Once these injuries can be ruled out, ultimately the patient is shifted for definitive care. So again, just rewind the case one. Case one, major airway injury. It was diagnosed during the A and B part. The ICD was placed. One-sided pneumothorax is there, right-sided. Ultimately, after putting the ICD, patient become hemodynamically stable. He was subjected for CT and ultimately went for the pneumonectomy. So this is actually the algorithm that should be followed in for all trauma patients, not only for the thoracic injuries, but since I am teaching you the thoracic injuries, so I placed it in the context of thoracic injury. Then how to evaluate these suspected patients with chest trauma? So clinical examination, no one can replace the clinical examination. And clinical examination in trauma, we teach them like look, listen, and feel. So what you look, you should look for a seat belt mark that I have told you during the previous slide, where a seat belt mark is there, and it tells you many of the things, that how much the energy has been transferred inside the chest and what are the organs that are lying just beneath that seatbelt mark that can get injured. That patients can have an aortic injury, that patient can have an airway injury, that patient can have the underlying lung contusions, that patient can have the rib fractures and the flail chest. So whenever you see any of the seatbelt mark over the chest, you should be very vigilant for these injuries. Abrasions, wounds, bruises, these all are the things that you should find out during the clinical examination in the inspection part, or we popularly say it look. So in look part, also see the O2 saturation and respiratory rate. Respiratory rate is very important in these patients. Usually we have the habit of finding out the pulse rate and the heart rate, and blood pressure. We usually overlook the respiratory rate, but respiratory rate is equally important, and it will guide you how severe the patient's injury are there. And sometimes they will tell you that this particular patient is going into the respiratory failure and this patient requires elective intubation and ventilation management. So never, never, never overlook the respiratory rate. They are one of the most important. And if I have given an example of pulse rate, heart rate, and respiratory rate, I will ask respiratory rate first, even before the pulse rate and heart rate. So it's very important. At the same time, nowadays pulse oximetry is available in every ER of even a small hospital. So O2 saturation is one of the agents that helps the treating clinician. Then listen for the breath sounds. Very important, because breath sounds, for the sound to be traveled, it requires a medium. So if there is a pneumothorax, then you will not be able to appreciate the breath sounds. So if diminished breath sounds are there on the one side as compared to the another side, there are chances that yes, the patients can have some abnormal thing inside the chest. That's why the breath sounds are decreased. So always listen for the breath sound, auscultate both the chest, apex, the base, as well as the posterior part, and always compare the level of the intensity of the sound with the contralateral side, whether they are equal or unequal. If unequal are there, there may be the problem. Then you have to find out with other clinical examination, the problematic is increased or decreased. At the same time, the percussion note, if it's a resonant note in a normal condition, but if it's a hyper resonant or tympanic note, then that may be abnormal, and it will give you a clue about the underlying pathology. The heart sounds very important, specifically in the cases of cardiac tamponade. They usually also found in the patients of the chest trauma, because heart again is a chest organ lying within the chest cavity. And if the pericardial tamponade or pericardial hematoma is there, that will ultimately lead to the cardiac tamponade, and the heart sounds are decreased, or we popularly say the muffled heart sounds. So you should always pay attention towards the heart sound also, because cardiac tamponade is one of the immediately life-threatening chest injury, and that requires clinical examination, then interventions, no investigations required in these conditions. Then feel for the bony crepitus, palpate for any subcutaneous emphysema or any abnormal things, or for the tenderness, because it will gives you a clue about the underlying rib fractures, or sometimes the flail segment, which is not clinically flail chest, but still multiple fractures in the pattern of flail is there. We call them the flail segment, and you can be able to appreciate bony crepitus, or at least you can be able to appreciate the tenderness in the patient. So they will give you an indirect clue that the patient has underlying injuries. Then the primary survey, the A, immediately life-threatening thoracic injuries like airway obstruction, laryngeal injury. You have to look in the A part, tracheobronchial injury, like in the first case one I discussed at the initiation of this talk. B, the tension pneumothorax and the open pneumothorax. Both are the conditions that are immediately life-threatening. You have to diagnose them clinically. In the C part, the massive hemothorax, cardiac tamponade, and traumatic circulatory arrest. Then there are the adjuncts like chest X-ray. Always these trauma patients cannot sit down. They may have the suspected spine injuries also. So we always take all the X-rays in the chest in these patients in a supine condition, and these X-rays are usually a AP view rather than a PA view, which are usually obtained in a medicine or the respiratory medicine or pulmonary medicine OPD for the interstitial lung diseases or infective lung diseases. But here trauma patients cannot stand up or cannot sit down, so we have to do all the X-rays in the supine positions. These all X-rays are AP view. Then the fast and extended fast focused abdominal sonography in trauma and extended focused abdominal sonography in the trauma. These are very important adjuncts that will also tell us about the presence of free fluid. Always pay your attention that fast is not a detailed ultrasonological examination of the abdominal organs. Fast is only and only subjected to find out the free fluid within the peritoneal cavity, within the pericardial cavity, or in case of extended fast, bilateral pleural cavities are also included. but we will only look for the free fluid. We are not looking for any of the solid organ injuries in that particular case, and it can be done by the emergency physicians, the surgeons, or even the normal doctors who are available in the ED, because you have to see only the fluids. You need not to image the viscera. Chest X-rays, very important. They are adjunct to the primary survey, and all these findings can be ruled out. That's why I gave you a lot of X-rays on the pre-test, because majority of the injuries are ruled out on the chest X-rays in the form of simple pneumothorax, hemothorax, pulmonary contusions. You can see the upper second X-ray. What you see, there's a hemothorax on the left side, the first X-ray, upper first X-ray, on my left hand side, you can see the homogeneous black opacity on the left side along with the subcutaneous emphysema. There is a simple pneumothorax on the left side with left-sided subcutaneous emphysema. Upper right X-ray, the left-sided hemothorax. Then lower right X-ray, you can see the widened mediastinum here. I will take you through the widened mediastinum. It may be one of the clue for the underlying aortic injuries. So here you can see the mediastinum is very widely opacified in the X-ray. And in the last X-ray, the lower right X-ray, you can see the contusions that are there on the right side, the non-dependent whitish appearance of a particular segment of the lung that appears as a pulmonary contusions, along with overlying rib fractures. So these all are things that can be ruled out even in the primary survey with the help of chest X-ray. So chest X-ray is one of the important investigations in these patients. But at the same time, chest X-ray is not mandatory to decide the use of ICD. Use of ICD in the primary survey are usually required for immediately life-threatening injuries, and any of the immediately life-threatening injury, whether it's a tension pneumothorax or massive hemothorax or cardiac tamponade or tracheobronchial injuries, they all need to be placed, or the open pneumothorax, ICD should be immediately placed to decompress these things, even without getting the chest X-ray. But yes, chest X-ray gives you further more information that the clinical examination is unable to give. This is something about the FAST. I will not go much in detail. This is the upper quadrant, the pericardial window. This is, you can see the free fluid here in between the liver and the kidney. So here we say this black streak, this is the free fluid that is there inside the abdominal cavity. So we say FAST positive. Here on the left side, you can see between the kidney and the spleen, there is a free fluid, the streak. So you can say the FAST is positive. And this fourth window is the suprapubic window where you can see the bladder and the Foley's catheter inflated within the bulb. Within the bladder, the Foley's bulb you can appreciate, and above that you can appreciate the free fluid. So this is something about the FAST. So these four quadrants are usually scanned. The first is the subgyphoid or pericardial window, then the hepatorenal window, splenorenal window, and suprapubic window. You also got one of the one of the question in the pre-test also regarding the FAST. This is something the FAST. E-FAST, when we extend our probe towards the bilateral pleural cavity scanning, then we can say it's the E-FAST. And during the E-FAST, we can also do a pneumoscan. Pneumoscan is nothing but this is the pneumoscan where actually you will find out the air between the parietal pleura and the visceral pleura. You can see here in the downward image, this particular shadow that is coming out, uh, this one. So here you can see a seashore pattern. So seashore pattern denotes that this is a normal finding and there is no abnormal collection of fluid or air within the parietal and visceral pleura. Even if there is air or fluid within the parietal and visceral pleura, the opposition between these pleura has been lost and the sliding sign has been absent. So in those cases, usually the barcode pattern arrived on the motion mode of the ultrasound. This is the motion mode where you can find out the seashore pattern, where you can see the sliding sign and the seashore pattern. But if there is uh, presence of abnormal fluid or air is there, then there will be a barcode pattern and it shows some abnormality within the chest cavity. So pneumoscan is not a diagnostic for the pneumothorax because never confuse pneumo with pneumo. It can also be abnormal in case of hemothorax because any abnormal thing between the parietal and visceral pleura, it will be positive and it will be evident as a barcode pattern. So here you can see a seashore pattern in a normal condition where the parietal pleura and visceral pleura, you can see these white lines, and this sand is nothing but the alveoli that are moving with the respiration. So this moving part with each breathing excursion will be appeared as a sand granules, and the fixed chest hole will be appeared as a lines. But in abnormal finding where apposition between parietal and visceral pleura has been broken down, they will be seen as a barcode pattern. So you can correlate between the same thing. Seashore is a normal pattern, barcode is an abnormal pattern. It shows that something abnormal is there between the parietal and visceral pleura. It may be air or it may be a fluid. Then something about the adjuncts to the secondary survey in the form of contrast enhanced CT scan of torso, because chest injury isolated per se are very rare. Usually the chest injuries are also associated with abdominal injury or nearby concomitant visceral injuries. So in all stable patients, always go for CCT of the torso. Torso means chest and abdomen both, because sometimes the associated abdominal injuries may be missed if you confined your CT scan to the chest only. But never, never, never do a non-contrast CT because it's not that much informative, and we have to repeat the CT scan once the patient arrived with us with non-contrast CT. Usually in the periphery, the physicians usually prefer for non-contrast CT because you need not to wait for the urea creatinine level. You need not to give the contrast, so there is no risk of the contrast sensitivity, and it can be obtained in a very fast way. But it is not informative one, and it is always better to do a CT scan. NCCT, whether done or not done, it will not affect much. So always do a CCT whenever you are offering a CT scan for a trauma patients for complete evaluation. Sometimes the digital subtraction angiography can also be required, but always consider it as a specialized investigations required in a very specialized population of the patient where actually you are going to do angioembolization, and very few patients require them. So even if you are not well versed with the DSA, need not to worry about that. DSA is a very sophisticated investigations required in a very selected population group, and per se majority of the patient doesn't require immediate DSA. If you are attending a patient that may require DSA, the patient has the time. You treat his all immediately life-threatening injuries, stabilize him, and then shift him. Now something about the management. Majority of the patients, as I told you, non-operative management, and they are the simple procedures in the form of good pulmonary toileting, or you can say the pulmonary hygiene, where patient should cough effectively and he should clear his throat. He should have deep breaths. Incentive spirometry in the form of spirometer. We always have a spirometer on the bedside of every trauma patient who is admitted towards our side. So a chest physiotherapy, incentive spirometry, pulmonary hygiene, good coughing, and good pain relief is what a thoracic trauma patient requires. Only a few patients required operative intervention, which I already discussed. So non-operative management, as I told you, the paradigm is good pain control, chest physiotherapy, and pulmonary hygiene. Few of the patients may require chest tube insertion also. So I will take you in detail in the coming slides about the chest tube insertion. Adequate analgesia, maybe IV, IM, or sometimes in severe injuries or when the pain is very severe on the visual analog scale, we should consider them for thoracic epidural insertion. So it will give a very good pain relief. Patient will be able to take deep breaths. Patient will be able to do a good spirometry as well as chest physiotherapy. and the pooling of secretions will not be there in the patient's lung, and patient will be all right in 3 or 4 days. But if the pain control is not there, there will be a vicious cycle that sets in. Patient is not able to take deep breath because of the pain. He will not be able to cough vigorously to cough out whatever secretions are there in his airway. So ultimately the pooling of secretions is there, and patient ultimately develops the pneumonia. And if there is a superimposed hemothorax is there, that hemothorax will get infected, and ultimately empyema will happen and patient will go in the sepsis. So that's why adequate analgesia, chest physiotherapy, and good pulmonary hygiene is very important, just to whenever it is required, and close monitoring of these patients, because two patients of the same age with same severity of the chest injuries will respond in a different ways. One patient may be all right in 3 4 days with all these management, and he will be discharged, but another patient may be sensitive for the pain, and whatever pain relief you are giving to the one patient may not be sufficient for the another patient. And if it is insufficient, the vicious cycle sets in, and ultimately the patients will dip in the chest injuries. So you should always consider a phenotypic response in these patients, or daily monitor the patients, check the severity of his pain, and escalate the analgesics as per the requirement. Then SCARF score. SCARF score is nothing but clinical guideline that will tell you that this patient requires admission or not. So if on the pain score is visual analog pain score is more than 5, we will give 1 score. Incentive spirometry less than 50% of the predicted one, then give 1 score. Respiratory rate more than 20, 1. Poor cough 1, total is 4. If it is 2 or more than 2, admit the patients from your ER and monitor him regularly. If it is less than 2, then you can safely discharge this patient to the home. Or if the initially it was 2 or 3 and now it is less than 2, now the patient is fit to discharge from your ward. So SCARF score is one of the score that is helpful for managing these patients, for predicting the outcome of these patients. For operative management, I must say, do not explore if you do not have these prerequisites. A blood bank that should be functional round the clock, a good ICU with an intensivist who can take care of these operated chest trauma patients, a very good experienced anesthetist, because in these patients usually the double lumen tube insertion is required. Sometimes we need to collapse one of the lung to operate on that particular site. Sometimes we have to do the lobectomy, or sometimes in a catastrophic conditions we have to do the pneumectomy. So many of times the patient become hemodynamically unstable during the operative procedures. So a very good experienced anesthetist is required, and at the same time you should be in continuous communication with the anesthetist while you are operating, so that the anesthetist should know that what will be your next step and how it will change the patient's hemodynamic. Then a trained thoracic or trauma surgeon is required, of course, for the operative management. But I must say, if your center is lacking any of these 4 prerequisites, it's always safe to transfer to a appropriate center with a communication with the operating surgeon. Now something about the laryngeal injury, uncommon but not rare. Their direct injury to the larynx, and they are again immediately life-threatening injuries. In the clinical examination in primary survey, you can actually find out the stridor, recent change in the voice, or palpable defect in the midline. So these are the clues during the clinical examination that can give you a clue that yes, the patients may have the laryngeal injuries. Again, the treatment, a definitive airway in the form of endotracheal tube placement, and then the operative intervention if you have those prerequisites. Otherwise, shift the patient within the intubated state to an appropriate center with prior information to the operating surgeon. So once you place the definitive airway, the defect will be bypassed and the patient's life will be saved. There is no more immediate threat to the patient, and the repair can be done in a specialized center in a delayed manner. These are few of the laryngeal injury patients that arrive to us. So here you can see that this particular patient has been received from another hospital who primarily treat him. So there is assault over his neck, and his trachea is directly visible from the neck wound. So the initial receiving doctor just placed an endotracheal tube through that defect and inflated the bulb. So basically he secured that airway, and then he referred to us, and ultimately we placed the tracheostomy and we repaired the defect above that tracheostomy. So again, who saved his life? The person who, the doctor who immediately attended him and placed him the definitive airway is actually saved his life. So these are the injuries that are very eye-catching and very dramatic in presentation, where you can see a large sounding wound in the neck where the air gets sucked in and expelled out, sucks in, is expelled out. Noisy wound is there, and the patient arrived to you in a conscious state. Then you must be vigilant enough to find out the rent in the trachea and place the definitive airway as placed in this particular patient. Tracheobronchial injury, as I told you in the first case, that was the tracheobronchial injuries, and usually the patients are unstable after penetrating injuries. They requires initial stabilization, chest tube placement, and once they are you place the chest tube, there will be a massive air leak. As I told, I have shown you in the previous slide, the grade 4 air leak was there. Along with that, there will be a lung collapse because lungs are not ventilated because of the cut in the interruptions in the supplying airway in the form of tracheobronchial injuries. And the surgical repair in the form of tracheal repair is what is required, with or without tracheostomy as per the need arise. Every tracheal injury repair doesn't require the distal tracheostomy, but the complex injury with larger defect are usually requires as distal tracheostomy that is a life-saving for the patient. It is something about the air leak. Again, I'm showing you one of the picture of air leak. You can see here. So which grade it is? The air leak is only during the expiration. You can see the air column, the water column is moving, and with every expiration, there is a air leak. So it is calculated as grade 3. In the previous video, you have seen continuous air leak. That was grade 4. Okay, let's see in this. So again, on coughing, the air leak is there. It's a grade 1 leak. You can see this also. You can see here, a lot of bubbles are there. And with the expression, it is there, grade 3 injury. Air leak is there. So depending on the magnitude of the air leak, it is there. Then we can find out the grading is according to the Surfolio's classification. Surfolio classification has actually graded them into the 4 grades. Grade 1 on forceful coughing, if air leak is there, then we say it a grade 1. Grade 2 on expiration, grade 3 on inspiration, grade 4 continuous air leak, irrespective of phases of the breathing. So as the graded increases, the severity of the air leak increases, and once the severity increases, it has more potential to derange your ventilatory parameters, and the patients ultimately will go in the ventilatory failure or respiratory failure. Tension pneumothorax, the diagnosis is purely clinical. These patients are usually present in the form of hemodynamic instability. So you got one of the questions on tension pneumothorax also, maybe two. So for diagnosis of tension pneumothorax, you doesn't require any X-ray. Only and only thing you need is do the clinical examination, and clinical examination will reveal hyperresonant sounds, hyperresonant percussion notes on the side of the pneumothorax, no breath sounds or decreased breath sounds, and patient is in the shock. So it's basically an obstructive shock where the pressure is generated so much in the chest because of one-way valve mechanism that it will obstruct the venous return. And once the venous return has been obstructed, there will be no more cardiac chamber filling, and there is no more blood to be pumped in the systemic circulation, and patient go in the hypotension. So we call it as a obstructive shock. Another example of obstructive shock is cardiac tamponade. The same happens in the cardiac tamponade also. Because of the pressure inside the pericardial collection, the cardiac chambers are not able to expand and they remains collapsed and there will be no blood filling during the diastolic phase and there is no more blood inside the cardiac chambers to be get pumped. So again, it will present as a hypotension. So both tension pneumothorax and the cardiac tamponade are the condition of obstructive shock where hypotension is there. And the treatment is, what should be the treatment of diagnosis is clinical treatment? Put, this is a life-threatening injuries, every second counts. Put a wide, large bore cannula in the fifth intercostal space in mid-axillary line. Initially, it was said that you should put in the mid-clavicular line, second intercostal space anteriorly, because anterior part is most accessible. But it has been found over the time that in majority of the patients, almost 50% of the patients, this needle will not reach up to the pleural cavity because of the muscle thickness over the anterior chest wall in the second intercostal space. That's why now it is advocated that in a tension pneumothorax, needle decompression should be done in the fifth intercostal space where the muscle thickness is minimum over there. And every needle decompression should always be followed by a chest tube placement. Needle decompression is only a time buying temporary procedure and it should always be followed by a chest tube. It is not a definitive management. So you can see here the fifth intercostal space, immediate decompression with needle thoracocentesis or needle decompression. Sometimes if needle decompression fails to release the pressure, you can simply put your finger in that incision and you just puncture the pleura. That is known as finger thoracostomy. And finger thoracostomy or needle thoracostomy should always be followed by a ICD or intercostal tube drainage or tube thoracostomy. So definitive management is placement of the ICD. On placement of the ICD, if there is a massive air leak, then definitely that patients require thoracotomy, but that number is very less. Rest of the patients will be managed with an ICD, and ultimately the ICD will be uh, removed in 3 or 4 days as per the response of the patient. If the patient requires thoracotomy, then the options we have are either repair of the lacerated lung or resection of that particular lobe, or sometimes whole of the lungs should be removed. That is known as pneumonectomy. It's a last resort and should not be done in a frequent way because it has an over complication in the coming time. Open pneumothorax, again a dramatic presentation. You can see here an open pneumothorax over the anterior chest wall. A large wound is there over the chest wall. You also got one of the questions on the open pneumothorax also. So whenever there is a size of the chest wall defect that increases more than 2/3 of the diameter of the trachea, then what happens? This will allow a least resistant path for the air to move, and air is always moved through the least resistant path. So whenever the patient inspires, the air will directly sucked out through this wound and the lungs will not expand, and ultimately the gas exchange will not happen and the patient will go in the respiratory failure. So what should be the management of these patients? Management includes the immediate management in the pre-hospital care or in the ER when you are evaluating the patients in the primary survey. At that time, you can do a three-sided occlusive dressing. You can see here in this particular video, it's a self-explanatory three-sided occlusive dressing where one side is kept open for the egress of the air, but again, during the inspiration, the ingress of the air will not happen. And along with three-sided occlusive dressing, once the patient is reached in the ER, then put a chest tube on the same side, but not through the same wound, from a different wound, because same wound is an infected wound. You can introduce the infection inside the chest cavity. Put the chest tube on the same side through a different wound, and ultimately ship the patient for a thoracotomy or thoracoplasty for the repair of the chest wall wound. So definitive management is thoracotomy or thoracoplasty. Three-sided occlusive dressing, chest tube, they are the immediate treatment to save the patient's life, but ultimately these patients require some definitive management because there is a defect in the chest that cannot be healed with the three-sided occlusive dressing. or the chest tube. They are only to preserve the physiology, to restore the physiology, and then shift the patient to the OR. I think it's clear in the question. You will tick the right afterwards. Massive hemothorax, again, if it is more than 1500 ml of the blood, that is accounted about 30% of the total blood volume. More in penetrating trauma as compared to the blunt trauma. Presented as in the form of hemorrhagic shock or in the form of absent breath sounds or dull on the percussion notes. Again, the clinical examination is very important. Management, again, management, first ICD is always placed. There is no doubt in that. Along with that, we will also calculate the volume. If volume is more than 1500 ml state, you place the ICD and 1500 ml came out, or you place the ICD and the continuous output is more than 200 ml for next 2 to 4 hours, it will be labeled as a massive hemothorax. But every massive hemothorax doesn't require operative interventions in the form of thoracotomy. If patient has 1500 ml output state or has a continuous output of 200 ml per hour for next 2 to 4 hours, it shows that the patient has continuous bleeding. But if patient maintains hemodynamics, still we can observe the patient with a non-operative intervention with ICD in place. But if patient is hemodynamically stable, with these findings, patient should be immediately shifted for thoracotomy. So massive hemothorax with hemodynamic instability, patient goes to OR. Massive hemothorax with hemodynamic stability, the patient maintains vitals, then this patient is not subject for operative intervention. You can shift him into the ICU, resuscitate him, and continuously monitor him. He will be come out. If still in any of the time, if patient is hemodynamically unstable, then shift the patient to OR. So the dictum is no thoracotomy unless a trauma and thoracic surgeon is available, because these patients who has that high magnitude of the blood output through the chest tube usually has some larger vessel injury, and that may require some skilled surgeon to control them. So never undertakes these big undertakings in the absence of a trained thoracic or trauma surgeon, availability of a round-the-clock blood bank, ICU, and a experienced anesthetist. Cardiac component, again, one of the immediately life-threatening injury, obstructive shock, where the blood is get accumulated inside the pericardial cavity. You can see this is the pericardium. This black shadow is the blood that is accumulated, and this pulsating structure is the heart. You can see. Okay, so this black shadow is blood. White line, outer white line is pericardium, inner white line is myocardium. So again, it will present as hypotension, angos neck veins, and muffled heart sounds. This is known as the backstrad, but every patient doesn't have the backstrad. Only a few patients, about 20 to 30% patients, have the classical 3 features of cardiac tamponade. Rest patients may have 1 or sometimes 2 features of the cardiac tamponade. And the best diagnosis is the clinical diagnosis. Sometimes you can take the help of fast agents. Cardiac tamponade, yes, this patient definitely requires thoracotomy in the form of clamshell thoracotomy, where you can take access of the pericardial cavity, decompress it, and then repair the rent in the myocardium, and then resuture it. So this is the thing, when you don't have the trained trauma surgeon or these facilities available, if the ultrasound is available and the facility to place a pericardial catheter is there, just do the pericardiocentesis and shift the patient to the center where the facility of thoracotomy is there. Because ultimate treatment of cardiac tamponade is operative intervention. This is about traumatic circulatory arrest. I will go in a very short form here. On the right hand side, I simplified the complicated table, which is in red, green, and gray color. So just look at the right hand side. If the patient is unconscious with no pulse or pulseless electrical activity is there, then intubate the patient and do a closed CPR. Means you need not to do a resuscitative thoracotomy at this place. you do a closed CPR over the chest compressions, plus also look for the ABC. If ROSC achieved, then the usual treatment for whatever reason the patient goes in the traumatic cardiac arrest should be followed. If no ROSC has been achieved, ROSC means return of spontaneous circulation, at least place the bilateral ICDs. After sometimes after placing the bilateral ICDs, ROSC sometimes achieved because the traumatic circulatory arrest are either because of the tension pneumothorax or sometimes because of the massive blood loss in the form of uh, massive hemothorax. If even placing bilateral ICDs, if no ROSC is achieved, then they are the candidate for doing the emergency room thoracotomy or ED thoracotomy, where you open out the chest and do a manual open cardiac massage. At the same time, you will also do a cross clamping of the aorta and control of the hemorrhage. So something about immediate life-threatening chest injuries that I already discussed. If there is no pulse PA, it's a traumatic circulatory arrest. Rest. If change in voice is there on the clinical examination, suspect laryngeal injury or major airway injury and secure the airway. If absent breath sound with hypotension is there, if note is hyperresonant, it's a tension pneumothorax. If dull note is there, it's a massive hemothorax. Again, needle decompression plus ICD, or in massive hemothorax, ICD. Then if the chest wall defect is there, look for the open pneumothorax. If the defect is so large that it will fit in the definition of the open pneumothorax, do a three-way occlusive dressing, put an ICD, and then shift patient for the surgery. If massive air leak or massive emphysema is there, always suspect the tracheobronchial injury, put an ICD and shift the patient for surgery. Muffled heart sound or hypotension is there, it's a case of cardiac tamponade. So by this simplified flowchart, you can actually correlate the things. Potentially life-threatening injuries, I discussed a lot. Majority of the times, either ICD, flail chest or pulmonary contusion, pain relief, ventilation, plus minus ICD if it is required. Traumatic diaphragmatic injury, surgery is required. Traumatic esophageal injury, surgery is required. Blunt cardiac injury, non-operative management, even no ICD is required. Traumatic aortic disruption, stenting is required, but that can be done in an elective setting. Immediate stenting is not required. You have one or two cases of aortic disruption also. So I will take you through the aortic disruption also. Impelled object, as I told you, if the penetrating object remains inside the body, we say it is an impelled object. Only the precaution you should take whenever a patient arrives to you is that it's very tempting to remove that, to pull out that impelled object and remove from the body. But never, never, never do that. Always these impelled objects should be removed under vision in the OR with a proper thoracotomy. So never pull out and remove the impelled object in the ER. They should be in the OR with the experienced surgeon. Rest. Other manifestations in the form of potential life-threatening injuries are like rib fractures. They are the commonest type of the chest injuries. And when they are in a specific pattern, they will give rise to a flail chest, which has a potential to derange your ventilatory efforts. So respiratory rate, if more than 18, inspiratory capacity on incentive spirometry is less than 75% of the predicted. Numerical pain score is more than 5. Poor cough reflex or poor coughing efforts, age more than 65 or more than 3 rib fractures. If these parameters are there, always admit the patients even if any of the two parameters are there. So this will guide you in your ER when you have a busy ER and lot of patients are waiting for the admissions and you have a limited beds. In those cases, you can actually find out these findings, and if any of the patient has more than two findings, three or more findings, then it's always wiser to admit these patients. So if respiratory rate is increased, that's why I told you that respiratory rate is very important for chest trauma patients. Inspiratory efforts on inspirometry is less than 75%. Is a candidate for admission. Very high pain, not relieving with the oral analgesics or IV analgesics. Poor cough efforts, older age groups, more than 3 fractures. So you should be vigilant for potentially life-threatening injuries for these patients. Subcutaneous emphysema, this is one of the precursor or a clue for underlying tracheobronchial injuries or lung parenchymal injuries. So you should always be vigilant whenever you see a subcutaneous emphysema in the chest trauma patients. These are few of the publications that we have during our tenure. So we published on almost everything, but I want to pay your attention towards one of the most important point that has been recently published is no role of antibiotic in patients with chest trauma requiring intercostal tube drainage. So here we collected the evidence that for a patient in which we are placing the ICD, only a single shot of prophylactic antibiotic suffice. After that, if patient doesn't require antibiotic for any other injuries or any defect, per se, the isolated chest injuries doesn't require any of the antibiotic for ICD placement. They can be managed very well without ICD, only with a single prophylactic antibiotic shot just before placing the ICD. After that, no more antibiotic is required. So this is something that usually asked to us during the seminars also, that whether we should place the ICD and whether we should continue the antibiotics or not. So no role of antibiotics in isolated chest trauma. Intercostal tube drainage, a very contentious topic. I will go through you in the details one by one. So chest tube, it's always easy to say that chest tube placement can be done by anyone. Yes, it can be done by anyone, but we should be very vigilant. So it has a sentinel hole, the last hole in the line, and all holes should be within the chest cavity. No hole should be outside, and it has one connector and it has a one PVC tube. So what should be the material, what should be the size, what should be the length, all these are the contentious topics. So I will tell you in the coming slides. The underwater seal always use this box type of the underwater seal rather than this collapsible polythene bag, because this polythene collapsible bag is only and only for pre-hospital care or for a temporary relief. But if the patient is in your ward or in ICU or in the ER and he reaches at a definitive center, you should always put such type of the containers rather than this plastic bag, because this is a collapsible bag and the environmental pressure will also collapse it. So the respiratory efforts will be increasing the patient. So this is the thing. How much water level? It has a preset water level. You should put the water level till that, and that ICD point should always be beyond that water level. It should always be drained within the it should always be submerged within the water level. Length of connecting tube should be good enough to reach till the end of the bed. It should not be extra large, because if extra large tube, there will be increased work of breathing. Then tidling means the level of the uh, fluid level that comes up and down with every breathing efforts. So whenever you go in the wards and take the rounds of these patients, always look for the tidling, because tidling is very important. If tidling is there, it tells you that the tube is patent and it is within the pleural cavity. If tidling is not there, either the tube has been dislodged or the tube has been blocked, or the pleura, visceral and parietal pleura get opposed, and for whatever pathology you place the ICD, that has been resolved, and this is the time to remove. So whenever there is a no tidling in the chest tube, either look for the obstruction or look for the thing that has been completed now, and this is the indication for removal of the ICD. Even if it is a blockage, you have to remove and you have to insert the new ICD, because blocked ICD will not work. So tidling is very important. Absence of tidling, physician should be very alert. Stripping and milking, yes, you can. Stripping and milking has limited role in these patients. When the clot is formed, you can milk it regularly so that it can be dislodged, and the tidling frequently can happen. How frequently change the saline? The saline should be changed by only and only treating physician, or if you are in a tertiary care hospital, then your GR should change. The healthcare hospital staff or healthcare workers should not change that ICD saline, because they don't have the knowledge of importance of this container. Sometimes they put the container above the level of the patient. then the backflow happens. Sometimes they block the container. So these things should not be happened, and it should always be done by physician. Here, what is wrong in this particular film? I deliberately put this film. It is within the container. The clamp is open. You can see the extraordinary length of this tube. So one column is already formed here, and the another column is formed here. So here the work of breathing will increase because patient has to breathe that much so that all of the fluid will go inside the container. So it should not be excessively long. It should be good enough so that the container will reach at the ground level from the bed. Extraordinary long length should not be there. When to remove the ICD? When your purpose for putting the ICD has been fulfilled, you have to remove. If you place for the pneumothorax, if pneumothorax resolved, no more tidling in the column is there, remove that. If you place for hemothorax, if hemothorax resolved, no more tidling, remove that. How to remove? 1 versus 2, always remove one and then on the next day or remove the second one. Never remove both the ICDs at the same time if 2 or more ICDs has been placed. Inspiration, expiration, it is should always be removed on expiratory phase so that pleuras get opposed. You should get one post-removal X-ray always after removing the ICD, but it should not be immediately after. It should be after at least 4 to 6 hours of removal of the ICD so that whatever pathology sets in, it will have the time. Immediately taking the chest X-ray after removal of the ICDs has limited value. Pitfalls in the chest tube management. Pitfalls are not complications, but encountered when you manage these patients with the ICD. First pitfall is poor selection of the patient. So if you find such type of the X-ray, it may not be a pneumothorax because it's a localized thing and it is in the dependent part. So it may not be a pneumothorax, it's a localized bulla that is in there. So you should not. What happens here? You can see that here the left level of the left diaphragm is higher up as compared to the right side, whereas in the normal condition, level of the left diaphragm is lower than the right one. And there is the bowel shadow you can see. And if you don't recognize them properly, you can place the ICD like placed in this particular patient. So always think twice before putting an ICD and don't put in a wrong patient. You can see here, not performing finger thoracostomy. Always put your finger before putting the ICD so that you can break all the adhesions between parietal and visceral pleura and you can actually place the ICD inside the pleural cavity. Otherwise, blind placement can lead to the pleural pulmonary parenchymal injuries. Too large an incision, incision should be small. Superficial fixation should not be there. Fixation should be deep so that dislodgement not happens. If superficial fixation is there, it can lead to subcutaneous emphysema and air leak. Like in this patient, you can see the subcutaneous emphysema. Here you can see the improper placement of the ICD where the sentinel loop is within the subcutaneous space. The patient has complete subcutaneous emphysema reaching up to the face also. So these are the complications that can happen because of the improperly placed ICD. 2 in, 2 out, both are the problems. Kinking, subcutaneous placement, intra-abdominal placement, these all are the pitfalls that you should always keep in mind. So here, what's wrong? It's 2 inside. It was over GLS insertion where it is pinching over the pericardium. The same thing you can see on the CT scan also. This ICD is pinching over the pericardium. So withdraw the ICD. Then if it is too less inside, then also here you can see the ICD is out and along with there is a subcutaneous emphysema. One of the eye is within the subcutaneous space. Kinking, you can see the kink on the ICD. So kinking can happen. Subcutaneously placed ICD. So if in the severe traumatic injury where degloving happens, a novice physician can put the ICD in the subcutaneous space. So the marker is the tidling will not be there. The air column will not move because it is not in the pleural cavity. It's outside. The breathing excursions will not be transmitted. Intra-abdominal placement. leak somewhere, you can see because of the leak, there is a subcutaneous emphysema. You can see here the subcutaneous emphysema. The ICD is placed. Improper filling of the reservoir, resultant pneumothorax, raising the ICD bottle above the level of patient. They should not be there. So the 0.6 and 7 can be overcome by improper filling, and placing over the patient is not recommended. Nowadays, digital drainage systems are there, so there is no effect. They put a continuous negative pressure of around 20 mmHg to the chest cavity, so there is no role of filling the water, and also you can put them anywhere comfortably, even above the patients, below the patients, because they are artificially putting the negative pressure. But at the same time, they are costly one. Another is clamping the tube while transfer. Never clamp the tube whenever you are doing interfacility transfer from one area to another area or one hospital to another hospital. Always shift with an open chest tube without clamping. It can lead to tension pneumothorax. Clogged tube, you can see a clot that has been dislodged from the chest tube. If chest tube has a clotting, always declot and replace the chest tube. Hamlick's wall, specifically in a persistent air leak of grade 1, we sometimes put the Hamlick's valve, but we should always put in a right direction. Otherwise, it can lead to a tension pneumothorax. Sometimes you can find such type of abnormal thing coming out from the chest tube wound. It's a bile that is coming out. The patient has a right-sided diaphragmatic mist injury with the liver injury, and through that, this bile is coming out. So sometimes in the late course, we find out that the patient also has the diaphragmatic injury. So take home message with the concluding slide. Thoracic injuries are very common in polytrauma patients. Most injuries can be treated with simple emergency room procedures. Operative intervention is required in only 5 to 10% of the patients in blunt thoracic injuries. Early recognition of life-threatening injuries in primary survey and surgical intervention key to a better outcome. Thank you. So now we can take the questions if permits.
Excellent, Dr. Naren. It was really elaborate. You took us through the entire spectrum of how patients present, what to do, what not to do. I hope participants were enriched, empowered now. There are a few questions here. We can take up this. One is somebody has asked name of the ICT tube available presently.
So ICD tubes, there is no specific company. They are the PVC tubes from the Romson, Polymed. Many of the companies are there. The important is the diameter of the tube. So usually we recommend that from 24 to 26 French is sufficient for hemothorax or pneumothorax. Previously, it was there that we usually place 40 French of the ICD, the wider bore diameter for the hemothorax, because it was saying that wider the diameter, more drainage will be there. But over the time, it has been quite well established that diameter has no role in the drainage of the hemothorax. More diameter, more pain will be there, lesser physiotherapy will be there, more requirement of the painkillers will be rare. Even a smaller diameter in the form of 24 or 26 will work the same way like a 40 French. So nowadays, the recommendation is that you should use 24 or 26 French for hemothorax. So diameter is important, and I think company is not matters. So it's a PVC ICD, the soft ICD. Another thing is never use a trocar ICD. Trocar ICDs are also there in the market. They have a trocar inside. So sometimes what happens in the experienced hands, they are all right. But in a novice hands, they don't know how much thrust we should give. And once the more thrust is there, then the intra-mediastinal injuries can happen. We come across many of such injuries. So we should avoid using trocar ICD. We should use normal ICDs.
Then there is one question about Malicot catheter. What is the role of Malicot catheter in present day practice?
So I think present day PVC, these standard ICDs are much better in the form of patency as well as drainage. So now no more role of Melicots. Yes, in the previous era, Melicots catheter were used very rampantly. But nowadays, the drainage and everything is provided better with the PVC chest tubes and Mellicores. I have not seen in last 7 or 8 years that any of the patients, even from the periphery, refer to us with Mellicores. Nowadays, it's out of favor.
What is the site of needle insertion in children for tension pneumothorax?
Yes, yes. So here I want to discuss something. What happens whenever the patient is in the catastrophe, hemodynamically unstable, the most accessible part is the anterior side of the patient because we can directly go over and we can do some procedure. Lateral part is always hidden and the posterior part is much more hidden. So we always avoid to do something on the lateral side or on the posterior side. That's why initially we say that put on the anterior side. Putting needle is an emergency. Do in within the seconds. So putting in the second intercostal space in adult is a problem because 50% of the time the success was not achieved because of the thick muscle mass that is there on the anterior chest wall. In the children, the muscle mass is very less. So there the success rate is very high and anterior part is most accessible part. That's why still it is saying that in pediatric patients, put the needle in the second intercostal space, mid-clavicular line, success will be there. But in adult patient, if you suspect tension pneumothorax, you have to put the needle, then put in the fifth intercostal space, mid-axillary line, because there the muscle thickness is minimum. So you will achieve the success rate. So that's why it has been changed in adults, but in pediatric patients, it remains same.
About the mediastinal emphysema treatment.
Mediastinal emphysema. So emphysema is because of something abnormal air that is leaking either within the pleural cavity or within the mediastinum. So first and foremost, if mediastinal emphysema is there, you have to find out the mediastinal structure. The most common is the tracheobronchial tree, the main trachea or the carina or the initial part of the mainstem bronchus or the esophagus. So these two are the main reasons for the mediastinal emphysema. Put the ICD if it is associated with the pneumothorax or when extensive subcutaneous emphysema is there. Put an ICD, then if patient is hemodynamically stable, shift him for an esophagogram with CECT chest. There you can actually find out the cause of the mediastinal emphysema and you can treat accordingly.
I think you've already covered all the questions very well, and you have a lot of accolades here in the chat box. I think you can see them. You will have a YouTube video of the session available after a week. So you can see the QPS YouTube channel. The entire session can be viewed later on. Meanwhile, I have put the post-test link also here in the chat box. But surprisingly, Dr. Narendra, about 7 of the participants got 20 marks today.
Yes, ma'am. I
That's
think
great.
I was expecting that because all are the clinical based scenarios and who are practicing clinically.
Normally, I've been doing, this is the third year I'm doing a series, but I haven't seen, full marks for any session. So here it was really good. And one thing very important, I think you have highlighted, and I'm very thankful to you. You brought that issue, antibiotic use while the drain tube is there.
Yes.
Most people misuse antibiotics and they continue these antibiotics till the time a drainage tube is inside, which is not needed. And I think your research publication on that is quite affirmative, which further strengthens the guidelines, which says only single dose of antibiotic is required, that too at the time of insertion.
Yes.
And I'm also very much surprised that you see trauma patients. So these patients may already have contaminated wounds, but still you did not find infection in these patients, and you could manage with the single dose of antibiotic. That is really something I think everyone should should get this confidence now that this is unnecessary. This contributes to antimicrobial resistance only. And I think much of these, Dr. Amit Gupta, I can quickly, while these people are doing the post-test here, and you are here, would you like to see the responses of the people on the Google?
Sure, ma'am.
Okay. Can you see my screen? This is how the scores distribution is. Let's go to the question wise. Here is the
Okay.
which of the following statement is true regarding chest injuries? Only
Yes, yes.
38.5% was correct. I hope the others, maybe you can discuss that
Yeah.
quickly.
Okay. So in this, my only purpose is I should make you aware about all the things regarding the chest injuries. So here, the less than 10% of the blood trauma chest requires operative intervention. That is the true thing. I just wanted to instill a confidence in you that whatever chest trauma patients you are attending, that will not require operative interventions. You can manage that patients. At the most, he will require the chest tube. The another point is clinical examination has limited role for evaluation of these injuries. No, clinical evaluation has the majority of the roles. Or even the life-threatening injuries are only diagnosed on the clinical examination. Even the X-ray is not required, and you manage them on the basis of the clinical examination. Whether it's a tension pneumothorax, it's an open pneumothorax, it's a cardiac tamponade. Everywhere clinical examination plays the main role. Hypoxia is the most serious consequences. Acha, this is question has been changed. Which of the
No, no,
following?
it's the same. It's the
Acha,
same tension pneumothorax.
okay. So tension pneumothorax is a clinical diagnosis and doesn't require any chest X-ray. It's clear. Cyanosis develops early and a good indicator of tension. No, cyanosis develops very late. And once cyanosis developed, I think he surpassed the reversible phase also. So cyanosis, and that too in the dark colored persons that we come across frequently, we cannot appreciate the cyanosis. So cyanosis is not a very reliable indicator. Hypotension is usually not a feature of tension pneumothorax. Hypotension is usually the feature of tension pneumothorax. It's a condition of obstructive shock. E-fast is recommended for the confirmation of tension pneumothorax. No, it's a purely clinical diagnosis. No investigation is required. That's why the first response is the right. Which of the statement is fast regarding management of tension pneumothorax in adult patient? Yes, immediate needle thoracostomy means second. Yeah, okay. So I deliberately placed it because now the guideline has been changed in the adult patient. In adult patient, the answer is immediate needle thoracostomy in fifth intercostal space, mid-axillary line. Because of thickness of muscle are minimum and the success rate of needle thoracostomy is maximum in fifth intercostal space. That's why I deliberately placed this as a first option. Rest over are open pneumothorax is characterized by all except, so which is not a characteristics of the open pneumothorax. It's a life-threatening injury. Yes, it's a life-threatening injury. Also known as sucking chest wound. Yes, happens when defect in chest wall is more than 2/3. Yes. Three-sided occlusive dressing is the no, it's not a definitive management. It's a pre-hospital care or immediate care in the emergency room. But ultimately, these patients require thoracotomy or thoracoplasty for the repair of that defect. Which of the following chest injuries is usually not associated with circulatory collapse? Yes, open pneumothorax usually doesn't associated with circulatory collapse, but tension pneumothorax, cardiac tamponade, and massive hemothorax are always associated with circulatory collapse. I think questions are straightforward, ma'am. That's why majority of the patients, majority of the doctors cleared them.
No, but still, there are many, this was
Okay.
only 40%. So I hope it improves in the post test.
Yes, massive hemothorax is not characterized by Rapid drainage of 1500 ml or more of the blood from the chest. Yes, it is one of the definition. Continuous drainage of 200 ml per hour for 2 to 4 hours. Yes, it is again a definition of massive hemothorax. Warrants thoracotomy even in absence of hypotension. No, only in the presence of hypotension, these patients requires operative intervention. Otherwise, it is not required.
I think reading the question carefully was also important.
Yes, yes,
Small little differences in the, although
yes,
it looks, yeah.
yes, yes. And color of blood is always a poor indicator. Okay, this is a clinical based question. Kussmaul sign, collapse, neck vein, hypotension, respiratory rate. These are all the signs of the cardiac tamponade. I told you na, every time the backstrad will not be there. All three classical signs are not there on clinical examination. One or two may be there. That's why I purposefully omitted the hard sounds that are not appreciated. And it is quite possible in your busy year where many of the monitors are beeping round the clock and many of the patients are shouting, you may not be able to appreciate those subtle sounds or heard those sounds. So that's why it's potentially life-threatening injury false statement often recognized during initial physical assessment. Okay, no, it is there cannot many of the times they overlooked. That's why this is the false statement. Diagnosis require high index of suspicion. Yes, even a small clue should be suspicious. Can be fatal if overlooked. Yes, they can be fatal. Flail chest is a potentially life-threatening chest injury. Yes, because it has the potential to compromise your breathing pattern. Which statement is not true about pulmonary contusion? So pulmonary contusion is a condition in which no operative intervention is required. So contusectomy is often needed is the right answer in this particular question. Concomitant rib fractures are often associated with, yes, they are associated in adult patients. Most common injury, yes, they are most common chest injuries. Typically evolve over 48 to 72 hours, yes. So they will take that much of time. Again, widened mediastinum. So what happens when we have the mechanism of injury, which is like two-wheeler ride head-on collision, very high transfer of energy is there. In those cases, we should suspect this type of the injury. Or there is a chest X-ray is also there.
Maybe I think responses, maybe can't see that, but
Okay.
question are those X-rays there.
So because of the widened mediastinum, it's the correct answer. Widened mediastinum. And the same patient is subjected for CECT torso. There you can see a grade 3 thoracic injury. Yes. Grade 2 is only the intimal flap. In that particular cases, pseudoaneurysm is there. That's why it's a grade 3 aortic injury. Grade 4 is overt rupture. Okay, again, the open pneumothorax is the clinical diagnosis, and true statement is prevent. A patient needs operative interventions as definitive. Yes, definitely, because the defect has to be repaired. Rest all are the interim measures, the pre-hospital measures.
I think without X-ray can't comment on this, but this is the right answer.
Yes, yes, yes. This is the right answer. Majority of has corrected and correctly placed the order. Okay, so this is something like ventilatory patient if immediately collapsed and a chest X-ray was done. It was a case of tension pneumothorax. You can see everything has been shifted towards the left, the mediastinum, everything, and homogeneous black opacity occupies all of the right pneumothorax. So this is the thing. So again, good analgesia, generous pulmonary toileting, and chest physiotherapy. That is all. Again, the same, all are potentially life-threatening injuries.
I think you can skip this, yeah. Without
Yeah,
X-ray, you can't make out.
yes. I think they corrected all. Ma'am, my Mac is going to die. Battery
Okay,
is going.
okay. Thank
So,
you very much. I think this was the last one also, radiographic science.
yeah, and all are correct. Yes, all of the above.
Yes, thank you so much, Dr. Narendra, for such an elaborative session here today. I think it was very much useful. The people sitting in the periphery will be able to use these knowledge at least, and much reassuring is that it is clinical. You don't need operative management, right? Suspicion evaluation is the most important part. And I think I will also end it like I was to talk about summarization of all these things. I think this is the same. One challenge is that anatomical uh, and physiological challenges there. Sometimes non-specific symptoms are there. You have to be suspecting about these injuries. Pain or difficulty breathing, general discomfort could be there. So if you need to identify the specific nature of the injury. Hidden injuries could be there. Other tissues, organs in the body can Dr. Narendra, can you elaborate a little more on the minor rib fractures? You did show about the flail chest that you may have with rib fracture. Most of the time, many people land up with the minor rib fractures. What should be the management?
For chest rib fractures and all these, ma'am, only the physiotherapy, pain relief, and good pulmonary hygiene is the crux that is required in all these patients. Because the problem is the pooling of secretions within the pulmonary parenchyma that ultimately get infected and converted into the pneumonia, or if associated hemothorax is there, then it is converted into a pyothorax. So good pulmonary hygiene, just physiotherapy and painkiller is the main part that is usually required in just rib fractures as well as pulmonary contusions.
For how long can this pain last?
It
How much
can
time does it take?
again I told you it's a phenotypic response. So in few patients it can last for over 6 weeks to 6 months also, depending on the severity of injury and the sensitivity of the pain to the patient. So few of the patients it can last for 6 months, but majority of the patients usually within 6 weeks they are all right and resume their routine activity.
What about bed rest or sometimes bed rest is advised? For how long it is needed?
Bed rest, if it's an isolated chest injury with rib fractures, bed rest for 1 or 2 weeks is all right. But if concomitant injuries are there, other serious injuries are there, then bed rest can extend, like the cervical spine fractures or thoracic spine injuries or liver injuries, diaphragmatic injuries, then it can increase depending on the severity.
Okay. I think then diagnostic challenges are, subtle findings, limited access, complex treatment protocols, especially in the emergency room. You may need multidisciplinary approach involving surgeons, pulmonologists, and critical care specialists. But a risk of complications is there. He, elaborated on the chest tube, how to put it, what are the complications, what are the pitfalls that we need to be caring about. And then patient stabilization can be difficult, especially those who are experiencing respiratory distress or hemodynamic instability. So taking care of effective pain management, oxygen monitoring are essential. Transport delays should be avoided because many cases this may not be available, maybe distance, traffic, or the ambulance itself, or the expertise was not available for transport. So this all coordination can be challenging. I think three very important things he has already highlighted: pre-hospital trauma life support, which is critical, which will save the life of the patient, and inpatient emergency trauma life support that we provide. Most of these patients can be saved. And finally, those patients severe injury, who need surgical trauma support is needed. I think Dr. Amit Gupta was one of the contributors in the standard treatment guidelines. We have recently published the 7th edition of this. In this entire, how do you approach trauma patients? How do you do the triage? What all pre-hospital care is needed? Then in-hospital emergency care, and followed by surgical trauma treatment for chest trauma, abdominal, head trauma. All those have been discussed in details. Indian Academy of Pediatrics have also recently produced guidelines for children, chest trauma in children. You may also go through these guidelines. And anyway, on the internet, you may find many other guidelines, whichever you feel is important, can be adopted here. And I think the summary slide is here. Dr. Narendra has already shown this. Immediately, primary survey should rule out these things, and this can be life-saving. Secondary survey can help if you can, identify, provide information on contusion, myocardial, aortic disruptions, diaphragmatic injuries, and tracheobronchial disruption, esophageal disruption. So all these things can be life-saving for the patients. I think with this we can call it a day. It was a long session, but a very, very useful session. I think this is one area. I was looking at the responses from the previous sessions also, and I saw trauma is something that I think most people feel that they need more exposure on these lines. And I think having a topic like chest injury was a very, very good topic for discussion today. I think if there are no more questions, we can thank him and conclude the session. You have already got the post-test in the link in the chat box.
Thank you, sir. Thank you for the wonderful and knowledgeable session. Also, thank you, ma'am, for your continuous support and, enlightening on all the topics so far, which is very much helpful for all our clinicians and all our staff working in the public health. So I have posted the post-test link. Also, feedback link has been posted. Please give your valuable feedbacks, which will help us to improve. And also, I have posted the YouTube link. All the sessions will be available on our QPS YouTube channel after 4 to 5 days. And your certificates will be issued within a week. So thank you all. You can, those who have not attempted the post-test can attempt. The link is there in the chat box. Thank you, sir. Thank you, ma'am.
Thank you.
One thing I like to say, many people are writing that they haven't got the certificate, but please, you would know that attendance, pre-test and post-test, these are the 3 mandatory requirements. If you fulfill that, then you will get this after a week. Please check your spam folder. Sometimes it goes into the spam folder. It may be lying there. If it has not been issued, and if you have fulfilled all the 3 requirements, you may write to stg.webinar@nhsrcindia.org email ID. Rest of all, you will get a YouTube link after 1 week. Some of you have written about the snake bite and other sessions. These are part of the other series. So we have to look at their end. So if here we will be able to take up only the NHSRC series topics that we do. I think with this, thank you, Dr. Narendra. We'll see you sometime again if we have some similar topic in future. May I also request the participants to suggest topics for future series which you think are relevant to you, because we may overlook some of these things. What is happening at the peripheries? What are your specific problems? If we are able to take up, we will definitely take up those things.
Thank you, ma'am. Thank you.
Okay.
Thank you. There are a lot of suggestions coming in for the next sessions. One is CPR, one is dog bite.
Okay.
I'll make a note of it, and then probably we will discuss over it.
Yeah, we did cover this. Sorry, this one dog bite CPR in the previous series, but maybe we may have to repeat that. Regarding this book, you can get it on Amazon. I can post the link here. It is available on. This is a comprehensive one. Emergencies. There is a full chapter on emergencies which talk about trauma, poisoning, foreign body, burns, even dog bite, snake bite. All these treatments are given there. What is this AERS topic? Can you elaborate on this? I'm not aware of it. Convulsions, yes, we had in the epilepsy in the first series. Maybe we can heat stroke. Oh, that's a good idea. Okay. Next time is the stroke. Next
Yes,
session
ma'am.
is on stroke. Don't
Acute
miss it.
stroke management on 15th of June.
Yeah. Dengue, yes. Okay. Siddhi, note down these topics.
Yes, ma'am. Yes, ma'am.
Yeah. Some are repeat topics, but some, I've
Ma'am,
been doing
dengue was
it.
our initial first lecture of series, the second series.
Yeah.
But we can, ma'am,
No,
actually think about it, and we can compile 2-3 sessions together, and we can.
Chikungunya. I did this as part of my another series that's parallelly running. So dengue, dog bite, I did last month. I did snake bite again. Nursing management on topics to benefit all the levels. Okay. Good suggestions. We can keep this in mind.
Yes, ma'am.
Certificate, you will get it on your email, whichever you use for registration. Siddhi will take 1 week's time to go through the attendance, pre-test, post-test. She has to link all these things and then find out who has completed all the 3 requirements. Don't worry, if you fulfill it, you will get it. We don't look at the scores. We just look at that you have attempted. That's all we want. Please do finish the post-test link. If you don't do it, then the mandatory requirement will not be fulfilled. Oh, there is a significant increase in the scores now. Pre-score was, very good. Pre was 8, now it is 19. Oh, that's great.
Ma'am, I have analyzed the previous sessions also, and the post-test, it's almost the averages of 16, 17, in between 16 and 17.
Yeah. So some,
Fitting
satisfaction
it's
for
all
us.
your efforts, ma'am.
Poisoning, yes. Primary management of diabetes, ketoacidosis. Yes, I think some of it will be repeat only, but we'll do it. Are the series one are also on the YouTube?
Yes, ma'am.
So I think some of it which we had taken earlier, you can watch that YouTube also. Yeah, even hypertension, diabetes, poisoning, CPR, dog bite, dengue, we had done this earlier.
Adverse effects after immunization, ma'am. AFI.
Okay, we can include this in one of the sessions. Okay. Can I leave? Yeah, post-test response. 84 people have responded already.
Ma'am, you can keep the post-test link live so that they can keep it.
Yeah. Okay.
Yes, ma'am.
I keep it live only.
Okay, ma'am. So that because if they are attempting, so they
Yes,
can.
I don't
once
close
they
it
open
usually, but I close the pre-test link because
Yes,
many
ma'am.
people
Yes,
are
ma'am.
using it later on also.
Yes.
So that then it, affects the scores.
Yes.
Siddhi, I've shared the editable link also with you.
Okay, ma'am. I'll work on it and ma'am received. Ma'am, can we end the session or like should I keep it? Can we end it?
हाँ, yeah.
Okay,
एक बार
okay.
लास्ट में लिंक डाल दो. Just I think everybody must have opened
Yes,
by this
ma'am.
time. मैंने editable link दोनों भेज दिए आपको.
Okay, ma'am. मैं कर देती हूँ. Okay. Thank you, ma'am. Thank you so much.
Hmm.
You.